I'm also presenting my department there in the present hospital, but also I wanted to show how my hospital was just 2 centuries ago. As you can see there, it was definitely not a hospital. It was called a farm. It was Sainte-Anne's farm. And the point, to be completely honest, is that it was done for those patients so chronic that nobody had to propose them any type of activity within the whole range of Paris. And so they bring these patients in this Sainte-Anne's farm to get some activity. And that's how, in fact, they built the hospital, as you can see there, and also that they used some cow to produce some milk, which was quite famous in Paris. So we in Sainte-Anne used this idea that increasing functionality of patients with schizophrenia, they might have some benefits for everyday life, for what they are coming at hospital for. And so we think that with Delay and Deniker, who proposed the first antipsychotic at a psychopharmacological approach, is in fact built on this idea that functionality also has a very large impact. So these are my disclosures of interest, and thank you for the joint invitation of Lundbeck Psychiatria for my coming there. So maybe the first question is, yes, everybody talks about, functionality, it should be much better. But no, usually no. If we make it simple, usually we have benefits. So why should we move from what we've been doing for decades, which is just reducing symptoms of schizophrenia? So that the first challenge is why should we shift from making it simple to make it a little bit more complex? So that's probably one of the 1,000 meta-analyses done by Stefan Leucht in Germany. He's extremely clever doing these kind of things. This one is a network meta-analysis. It's a little bit different, where you compare face-to-face protocols, but then you guess if A is above B, B is above C, then A is above C. So you infer some specific activity. So you increase a lot your capacity to see exactly what is the benefit of one treatment compared to the other. And as you can see, there's a kind of hit parade, with the ones on the left having the higher efficacy and the one on the right having the lower one. But never forget about the confidence interval. What is our reliability to distinguish those different treatments? And if you look at the kind of golden standard, the chlorpromazine, which was used first in Sainte-Anne Hospital 2 centuries ago, 1.5, well, within its confidence interval, all antipsychotics are comparable, except for clozapine. And we know for clozapine, because it has a very strong efficacy, is always also associated with a lot of side effects, such as weight gain, saliva, and so on. So, do we have enough to distinguish the interests and limits of all these antipsychotics compared to chlorpromazine only on efficacy? And the answer is there, and then it is no. So maybe that was the idea for which all those mega trials, they decided to go a bit further, not looking at just the reduction of the PANSS, but more precisely if we could have different types of endpoints. So you all know the CATI study, a very large one, and also thousands of publications. What was interesting is that their endpoint was a very pragmatic one. Did you keep on taking your treatment? That was the efficiency point. So definitely very far from efficacy. But nevertheless, it was pinpointed, because the fact that when you stop your treatment, you have a tremendous increase of risk of relapse was in fact considered as sufficient to show a benefit. So that was also the idea with the CAFE study, also the Cutlass, the UFEST, all those studies use that, with this idea that efficacy is probably not enough. I like the UFEST study because, of course, it's first episode patients for which we know we're going to have the higher capacity to see if there is any benefit. And it was a very, very clear result. Well, if you are completely restricting your analysis to the PANSS, all treatments are equivalent. You have a first episode of psychosis, you get antipsychotics, you're going to be improved. But if you get a bit further from just efficacy and assess efficiency, what does it translate into real life or everyday life of these patients, then with a GAF, you have some significant difference, where some treatments are having more this type of activity than others. And even the CGI, because we as clinicians, we probably mixed the idea that we have a benefit on the symptoms side, but we also want to increase this quality. And then we have strong, significant difference. So, you know, for us as clinicians, this is telling a lot. This is telling that just relying on the symptoms is not enough. We could do better, and this is how we could see the benefit of specific treatment. So we had this kind of discussion about, do we have to shift from efficacy to efficiency? So the efficient treatment is not only the reduction of the PANSS and definitely also the CGI, but also meaning that if we get to functionality, to other type of aspects, is it so important to reduce symptoms for 8 weeks? Or do we have to see if the patient is able to go back to work after a year? But that, of course, means different type of assessments and protocols where you have to go on the longer term. The maintenance has been definitely put forward by a lot of those studies because this is how your patient is going to avoid the relapse. Stopping your treatment is the first cause of relapse. And then we had this idea that getting to assessing functionality very quickly, even in the acute phase of the first episode, and then see if it's going to be improved, is another way to capture the benefit of what we do for our patients. And you know, in the American way, the functionality is completely the equivalent of going back to work, having some productivity and a salary, which might be a bit different in Europe, but whatever, it's definitely a very interesting way to see also if we are really improving our chances of our patients to go back to work. The idea also with this efficiency concept compared to efficacy is also including side effects. Why is it so? It's because we know that cognitive functions are so important to increase your full response to the treatment. And when you have sedative effects, when you have weight gain, when you have extrapyramidal symptoms, all of which dampen your quality of cognitive skills and then might, at the end of the day, reduce your chance to get to full clinical and functional remission. So the efficiency is now more and more popular with this idea that you capture much more than just the symptoms of the disorder. So to benefit of this better outcome, what should we do? If it's so important, if this is a way to reflect the benefit of this treatment, what does that mean at a clinical level? How should it translate in practical fact that we should look at? And the points that are now very convergent is that we should do quickly and on a longer term using higher demanding endpoints. Why is it so? Well, you all know this study from Nancy Andreasen. A lot of emphasis was proposed for the point that with more neuroleptics and antipsychotics, you have more brain loss. But the point is, this might be true, but if you specifically look at the times for which you had sufficient symptoms to be considered as a relapser, this time is connected, is directly and significantly correlated to the size of the white matter. So it really pushed this idea that acute disorder is neurotoxic. So there is a toxicity, maybe of the treatments. It's never completely safe to take treatments. We would like to avoid treatment. But the disorder per se is even much more neurotoxic. So whatever we do to avoid the presence of these highly important symptoms, we would protect the brain. So, you know, it's a kind of balance which is not so easy to manage, of course. The first point is then avoiding this disorder. But for that, we can begin to protect our patients after a certain time, which is the time for which, after the first onset of their symptom, they go back to see a psychiatrist. And this is the duration of untreated psychosis. And as you know, for some of them it might be a couple of weeks, and some of them it can be 5 years, because for some patients they do not ask for care and they have no treatment. Does that have an impact? And that's important, because if the disorder is neurotoxic, we should observe more damage for those patients that were not treated before the occurrence, between the occurrence of the disorder and the beginning of the treatment. That is the case. And I would like just to remind us as clinicians that this is not so easy to see. That was a very large prospective study where you looked at after 4 years and you found the level of functionality of those that were treated quite quickly compared to those that were treated, in fact, quite a long time afterwards. It was not significant. But after 8 years, this significance was very large. So that means, yes, the duration of untreated psychosis means a lot about the at the end of the day level of functioning, but you will not see it immediately. And so that is really a negative point, because for the patient, they will not understand that. It really means looking for a decade rather than just 1 or 2 years. So that means we should know it as clinicians, and we should also show this information for the patients. You remember in my hospital that we have some specificities, is that we have a modern director, and so we are not allowed to write down anything. We don't have any paper now. We only have computers. Just guess how patients with psychosis like you being behind the screen and, you know, writing silly things on them. They hate it. So I gave the commitment to all my colleagues that all the screens should be shared between the patient and the doctor. So whatever you write down, the patient is able to read it. And of course, you don't write exactly the same things when you know that the patient is also able to see it. Whatever, with this specific type of activity we have in my hospital, we also have a lot of slides, and we share it, all of this together, in order that the patient can see scientific material. And so this slide, for example, I show it nearly to all my patients with psychosis, explaining why if you have a relapse and you say, well, you know, I'm a bit not so well, my voices are coming back, but I know it might be stress, I've smoked a little bit of cannabis, so maybe, you know, next week it's going to be better. And of course they don't come back, and 3 months afterwards they come with an acute episode. I said, if you do that, if you come to see me because you don't feel so well, you are going to reduce your level of functionality for a long time. So this is evidence, that's not my opinion. This is scientific evidence. And the patients with schizophrenia, even if they're completely delusional, they completely understand scientific material, because it's not my opinion, it's what studies showed. And if they ask for more information, I even give the PDF. Of course, they have to speak English and have a relatively high IQ and so on, but whatever, it's a different way to cope with that. And really, I hope that you are also convinced that it's a good way to go, because it means that the patient is reasonable, responsible, and being also committed. I like this study from Robin Amsley from South Africa. I'm sure that you already know this study, where he treated patients with schizophrenia on the first episode. It was in South Africa, and all those patients were initially responders. And then he proposed a long-acting injectable antipsychotic for 2 years, just to follow those patients that were good responders. And the level of relapse was very, very small, below 10%. So really, when you have a good treatment, okay, you have a very good efficacy, and then a very good protection. That's not really a surprise. I know that you all know that. But maybe what you don't know is that afterwards, because of the protocol, Robin Amsley asked all of them, now that you had your first psychotic episode, you had this treatment for 2 years with a very good efficacy, just look at that, very few relapse. Now, if you want, we could stop the treatment. First episode, so 2 years is really even above what is usually proposed. So as you guessed, nearly all of them decided to stop their treatment, saying, now I have absolutely perfect, no remaining symptom. I want to stop this antipsychotic treatment, and because I feel completely normal. You know what's the relapse rate of these patients that were so nicely stabilized for 2 years? 94%. So that means nearly all of them relapsed. So for me, it really is one conclusion sentence. 2 years is not enough. Even if you have a very good response, even if you have absolutely no response for 2 years, you have schizophrenia, and 2 years is not enough. What does it mean? Should it be 3, 5, 10, 20? I don't know. But 2 years is definitely not enough. Nearly all of them had a relapse. This idea with treating patients with long-acting antipsychotic is that we might not only just avoid the symptoms to be present, but maybe being a little bit more neuroprotective, reducing the risk to lose their white matter, and so using all their different types of neurocognitive schemes. This is the very first study where the oral form was compared with the long-acting form. So that's very interesting because in this approach, you really see the benefit of just having it once a month and very regularly compared to, giving the drug as an oral form to the patient and just have a look about what will be the impact. So it's much more a question of psychopharmacology rather than a purely chemical approach, because this is the same compound. And what you see there, looking in the frontal cortex, that the white matter is being lost after 6 months for these first episode patients when you take the oral form, even though it's completely stable and not different in patients who took the long-acting injectables. So this is not a matter of the ones taking a treatment A versus B. It's exactly the same product, but it's the difference between having very, very smoothly every day for 6 months compared to those which should take pill every day, but of course we know never do that completely 100%. So that means a neuroprotection because you took it very, very regularly. But you could say that, I'm not treating fMRI. What I'm treating is a patient, but this study looked at that too. It tested the cognitive skills of these patients and how you could understand this white matter loss according to your quickness of response on a very simple paradigm. And what they saw was that a very high correlation existed with your quickness of response and the importance of the white matter you're losing. And for these patients, after, for example, 2 years being treated correctly, being nicely protected, they will be much quicker. But when you are quicker and go back to work, then you are more able to answer the demands, you are more able to interact with the others, so you will get higher chance to have a better way of functioning. So this really translates into something concrete at the clinical level. Just in the same range, even though it's definitely not the quickness of cognitive skills or fMRI, or MRI, should I say, it's the comparison of two techniques. One of them is the individual placement support, which is much more the American way. People are going out of hospital because they have no more schizophrenic symptoms, and they are thrown into a working place, and we try to help the patient to keep their job. That's usually the American way. In Europe, what we are usually doing is the patient had this relapse, it's much better, it goes out, and we try to train the patient to be so much better that she will be able to go back to work. And so the idea, and I don't know exactly what's your feeling about that, but in France we had this idea that, if you push the patient too hard back to work, even though he's got still some remaining symptoms, it's going to be too stressful. And we had a risk of relapse. But the point is, it was exactly the opposite. You see those patients that were thrown to their working activity. Of course, they work more, not a surprise, more hours being working, no doubt. But if you look at the rate of those getting back to hospital, it was decreased compared to those that had a support initially and then were sufficiently well to go back to work. And if they go to hospital, it's on a shorter term. So the idea with this is saying that going back to work means more interaction, more cognitive skills being solicited every day, which will then increase the quality of the outcome. The last point is about the difference of antipsychotics to increase our chances to improve this level of functioning. So for that, I would like to talk about the QUALIFY study that was just published by Naber, and on a very first time, long-acting injectables were compared as a face-to-face study, and also the very first time for which the endpoint was not efficacy, but in fact was functionality. It was this time then meaning its effectiveness and not efficacy, and so the aripiprazole, which was mainly around 400 milligrams, was to be compared to paliperidone, which was mainly 100 milligram for this follow-up controlled study. The endpoint was the QLS. The QLS is a quality of life. It was initially for the negative syndrome of schizophrenia. I won't get into too much details because it's a relatively time-consuming and complex instrument, but it's very precise about a number of these definitions, about how is the level of your social interactions, are you able to function for whatever university, working activity, and so on. Do you also have some cognitive skills that are damaged by your schizophrenia for motivation, anhedonia, empathy, and so on? And are you participating into everyday activity, for example, in your one place or a household? That's one example just to show you how we are quoting patients with a quality of life scale. So to rate relationships with significant persons, caring and sharing with people, and so on. These are a list of questions, and then you say, well, the patient definitely does have it, or it's a perfect, adequate involvement. So this is how we quote the QLS in order to have a better idea about the efficacy on quality of life. That's the design of the study, so it's a very simple one. Whatever it was the treatment, you take some time to get the specific treatment, which was either aripiprazole or paliperidone, and then you have a period where you begin the injectable treatment, and then of course you have the follow-up, which was for 20 weeks to assess if we had any type of difference for quality of life. I won't get into too much details, but the idea is that the patients had to be mildly ill, not acutely severely ill. So it was relatively rough, broad inclusion criteria. And the acute psychotic exacerbation of psychotic symptoms was being screened. That's also the specificity of the sample. I won't get into details, but it just gives you that the major aspects of these patients were really comparable between the two samples. The average was also quite comparable, around 400 milligram there, around 100 milligram there, so really what we use in everyday practice. So that is the result. The quality of life scales is being improved by both these treatments. So that's a very important point. Whatever you do when you shift to antipsychotic on a monthly basis, you will have a more smoother and regular protection by the antipsychotic, and that will translate into an improvement of your quality of life for your patients. So that is the first very good news. The second one is these treatments are not completely equivalent. And in fact, aripiprazole had a higher efficacy on the QLS after 28 weeks compared to the one on paliperidone. What was interesting is that this improvement there of the quality of life was a significant one. So it was clinically meaningful. It means, yes, the patients were really able to have a better functioning. That was relatively comparable with the CGI, which was the severity level according to the clinician, where you had a better improvement with aripiprazole compared to paliperidone, but also that both treatments were active on the reduction of symptoms. When you try to see which one aspects of the quality of life instrument was explaining such a larger impact for aripiprazole, you can see that the main one was intrapsychic foundation, which was mainly the cognitive skills of the patient, anhedonia, motivation, empathy, and so on. And so those aspects which really reflects the negative syndromes should be, or appear to be, more improved within partial agonists, and I'm sure that we will have some explanation of why we would have this benefit with aripiprazole. So these are the differences. So all of them were definitely a bit better with aripiprazole. Once again, those two treatments were efficient, which is the good news, and the benefit might be more obvious for antipsychotic foundation. So just to conclude, we face a lot of challenges when we treat patients with schizophrenia. The best criteria, which now shift from just 20% reduction of the PANSS or 30 or 50, is now more taking into account of functionality, but which one for which instrument, what level of improvements, there's no yet consensus. A lot of unspecific risk factors are being involved and usually not measured, so we have poor quality of their assessments. The level of agreement of the question of functioning is still low and should be improved. There is low level of agreement between patients and care providers. When we talk to our patients, say, well, you've got a fantastic improvement. A lot of time they say, oh, absolutely not. Why do you say so? And an early damage of the disorder on these cognitive skills really should be our nightmare, the one that we really want to avoid systematically. There is increasing interest in more complete remission, and this is exactly what is asking the patient. So this is the way we should go also. There are more clues to be discovered. There's some very interesting studies where the mother who's been also psychotic, during her pregnancy, preventing the risk for the baby to come, some studies shows that we might have a better protection for these at-risk subjects. There are also virtual circles. Either when you facilitate functioning, you will in fact facilitate the reduction of symptoms. We have also this important factor that long-acting, once monthly antipsychotics might have a better protection on your brain. And if you do that, never forget that you have to avoid those that damage it directly, which is usually substance abuse, such as cannabis. And focusing on side effects is part of the process, which definitely also is the point. So before achieving fully personalized treatment that everybody's dreaming on, we still have a lot of work. Thank you very much for paying attention.
Stummer wirs und immer stummer, Lüftchen weg, selig Stauf, bringe du